Yeah.
Okay. Well, hi everybody. Thanks for inviting me to talk about one of my favourite things to do as a perfusionist. So I'm going to talk to you about deep hypothermic circulatory arrest. So this is what we'll be looking at. We'll look at what is deep hypothermic circulatory arrest, why we use it. Then we're going to look at blood gas analysis. We're going to look at the pH and the behaviour of gases when we cool. Then we're going to look at pH stat and alpha stat. And then the conduct of circ arrest, cerebral perfusion, and then monitoring. So we'll start with classifications of hypothermia. We've got mild, moderate, and then deep is classified as less than 28 degrees. And this is what allows us to do circulatory arrest. And circulatory arrest is complete cessation of the circulation. And we use this profound hypothermia to preserve organ function. So with preserving organ function in mind, this is a fascinating example of hypothermia and how it preserves organ function. This is Anna. She's a doctor as well. And when she was 29, back in 1999, as a trainee orthopaedic surgeon, she was skiing in Norway. She was a good skier, but on this occasion, she had a skiing accident. She fell headfirst on a layer of ice near a waterfall. A hole opened up and she was dragged in headfirst, and there she remained for about 80 odd minutes. After a certain time, she had a cardiac arrest. She was in an air pocket, so she was able to breathe while she was before the cardiac arrest. So she was trapped under, I think it was like 20 centimetres of ice for around about 80 minutes. The body cooled down to 13.7 degrees. She was rescued, put on bypass to rewarm, woke up 10 days later quadriplegic, which she was most annoyed about, saying, "Why did you bother rescuing me?" But that resolved. After 2 months in ICU, she made a full recovery, but just had minor nerve injury in her hands and feet. But the point about this story is prior to the cardiac arrest, she had enough time to perfuse and cool her organs. And she's now actually a radiographer, so radiologist rather. So anyway, the reason why we use circ arrest is to facilitate complex aortic arch surgery, because during this surgery it's impossible to perfuse the brain through cerebral vessels using bypass. So as cellular metabolism is decreased with hypothermia, this confers cerebral protection. And for every 1 degree C reduction in temperature, the cerebral metabolic rate for oxygen is decreased by 7%. So now we're going to look at blood gas analysis during circ arrest. So if we start from the beginning, first of all, we're going to look at pH. pH is a measurement of the concentration of hydrogen ions, and pH is equal to the minus the log of the concentration of hydrogen ions. So hydrogen ions do not exist free in solution. They react with water molecules to form hydronium ions. And with a pH of 7, the concentration of hydrogen ions is 1 × 10⁻⁷ molar. So we're going to look at why hydrogen ions are so important, which is kind of not in keeping with their very low concentration. So intracellularly, pH is maintained at the pH of neutrality, and for aqueous systems, this is when the hydrogen ion concentration equals the hydroxide ion concentration. And the condition of neutrality is based on the amount of water that dissociates. This is very temperature dependent. So with higher temperature, you get more dissociation. Hydrogen and hydroxide ions are still neutral, but because the hydrogen ion concentration is higher, the pH is lower. So this just shows the dissociation of water. With increasing temperature, this reaction is driven to the right, leading to more dissociation. But as temperature decreases, you get less dissociation occurring, therefore the pH is higher. So moving on to how pH changes with temperature. This is the change in pH with temperature is pretty much linear. For every 1 degrees change in temperature, there's a change of 0.15 pH units. So the pH of neutrality at water at 25 degrees is 7, and the pH of neutrality at water at 37 is 6.8, and this is the mean intracellular pH. And the reason why intracellular neutrality is so important is because this is the ideal pH for metabolism. So why is pH so important? It has a profound effect on metabolism because at a neutral pH, all known low molecular weight and water-soluble biosynthetic intermediates possess groups that are essentially completely ionized. So the advantage of this to the cell is that these metabolic intermediates are then trapped within the cell. And the effect on intracellular proteins such as enzymes, receptors and transporters and so on is the pH-dependent charge determines their 3D shape and therefore their binding characteristics. So intracellular pH is the most important pH in the body, as the intracellular fluid is responsible for the majority of the body's total buffering of respiratory acid-base disorders. It's also responsible for some buffering of metabolic acidosis and alkalosis. So the intracellular pH is maintained by buffering, adjustment of arterial PCO2 and a higher extracellular fluid pH. So to maintain an intracellular, I'm going to have a drink. Sorry. To maintain intracellular pH as neutral, the intracellular pH changes with temperature, and this is to maintain a neutral pH. So protein buffering as a result of the imidazole group of histidine maintains this pH temperature relationship. So the imidazole group of histidine has a degree of dissociation, and this is known as alpha, and this alpha remains constant with temperature changes. So alpha directly affects the net electric charge of proteins, and therefore the protein charge remains constant. So that means that proteins function optimally despite temperature changes. And this protein buffering is the most important intracellular buffering system to maintain a neutral pH. So the degree of ionization, also known as alpha, of the imidazole groups of intracellular proteins remains constant despite a change in temperature, and this is the alpha stat hypothesis. And by maintaining alpha, the net charge on all proteins is kept constant despite changes in temperature. So the point about what I've described is that alpha stat is a physiological response to cooling, and this is exactly what happens to hibernating animals. So now we're going to look at blood gas analysis during circulatory arrest. So starting with Henry's law, this states that the mass of a gas which will dissolve in solution is directly proportional to the partial pressure of the gas above the solution, and it's expressed with this equation. So dissolved gas and free gas are in a temperature-dependent equilibrium, but this law assumes that temperature is unchanged, but the solubility of oxygen and carbon dioxide increases with decrease in temperature, and so therefore their partial pressures decrease. And this shows how the solubility of oxygen and carbon dioxide change with temperature. And just to note that CO2 is actually 20 times more soluble than oxygen and is very soluble at low temperatures. So this slide just summarises what happens to blood when you decrease temperature. there is decreased ionisation of water, increased solubility of gases, which results in this physiological alkalosis of hypothermia. So, for example, at 20 degrees, pH is 7.65 and PCO2 is 2.4. So, when we measure blood in the gas analyzer, the electrodes are actually calibrated at 37 degrees. So if you measure a cold blood sample at 37 degrees, the partial pressures will appear higher than they are in the actual hypothermic patient. You can temperature correct the blood, and the analyzer calculates what it would be at that particular temperature. So there are two ways of interpreting blood gas analysis in the hypothermic patient. There's alpha stat and pH stat. So with alpha stat, the blood gas is not corrected for the patient's temperature. So you measure it against the parameters at 37 degrees, and you maintain those parameters as they should be. And this maintains a constant dissociation state of histidine, which allows for your physiological alkaline drift and the maintenance of intracellular pH. The total CO2 content doesn't change, and the actual PCO2 will be lower than measured at 37 degrees, which will manifest itself as a relative respiratory alkalosis. Cerebral blood flow is related to metabolic needs. So with pH stat, the blood gas is measured at the patient's actual temperature. So you correct for the patient's temperature. So you maintain at the temperature the patient is at, a pH of 7.4 thereabouts and a CO2 of around 5. So using the example of cooling a patient to 20, at this temperature they're alkalotic and hypercapnic, but with pH stat, they will have a pH of 7.4 and a CO2 of 5. So how do we achieve this? We add CO2 to the bypass circuit, and that results in acidotic and hypercapnic blood and a relative respiratory acidosis. And so the CO2 content is increased because we're adding CO2. And cerebral blood flow and the cerebral metabolic rate for oxygen become uncoupled around 22 degrees, and blood flow is then pressure dependent. So why is alpha stat and pH stat even a consideration for circulatory arrest? It's because CO2, arterial PCO2, is a major factor on cerebral blood flow. And so this is important when planning circ arrest, because we want the brain to be as cool as possible. So with pH stat, we increase arterial PCO2 because we add CO2 into the circuit because we're temperature correcting. We increase cerebral blood flow, therefore, which results in faster homogeneous cooling of the brain, improved oxygen delivery, but we do have loss of cerebral autoregulation. There's also an increased embolic load risk, the risk of cerebral edema. With alpha stat, cerebral autoregulation is preserved up until about 22 degrees. There's a reduced risk of cerebral edema and emboli, but there's possible uneven distribution of blood flow. What we used to do at St Thomas's, when we used alpha stat to cool, around 20 degrees, the anaesthetist would take a jugular venous sample, and the saturation would be around 80%. So we would just carry on cooling and cooling until the jugular venous saturation reached 97 to 98%. But with pH stat cooling, the saturation was always arterialized, so we didn't end up, well, we stopped taking jugular venous saturation, and also with the advent of NERS monitoring, we don't do that anymore. So as far as bypass is concerned, the conduct for circulatory arrest is to obviously go on bypass, establish full flow, cool, depending on the clinical situation, whether you've had to crash on bypass or not, but hopefully you could cool with a decent gradient so you can cool the patient properly. Ice on the head to prevent passive rewarming, and pharmacological protection. Maybe you'll stop giving that now after Mike's talk, I don't know. We measure temperature, obviously, of the patient, nasopharyngeal temperature, and obviously now we have NIRS monitoring as well, so we can see the brain saturation increase as we cool. Optimum temperature depends on the surgery that patient's having and the surgical preference. But it's also important to note that oxygen consumption still occurs. There was a study, again, done on pigs, where they cooled the pigs at 8 degrees and found that there was still a basal metabolic rate of about 10%. And this study suggested that a safe circ arrest time is around 40 minutes. Glucose management, you get hyperglycemia with the surge response. And when you cool, you get less insulin sort of released as well. And obviously hematocrit management, matching the temperature, because as you cool the patient, the viscosity of the blood increases, which can reduce your microcirculation and maybe cause ischemia. So if we hemodilute the patient, that improves your blood flow in these areas. So our method at St Thomas's is to, for blood gas management with circulatory arrest, is to commence bypass, start to cool. We do an early baseline gas as alpha stat, and then we switch to pH stat gas measurement. Then we start to add our CO2 with reduced sweep gas, and this results in what we term as luxury perfusion of the brain. We monitor the CO2 regularly with pH stat blood gas management, and then before we switch off to circulatory arrest, we switch to alpha stat blood gas management, turn off the CO2, and we increase the sweep gas to bring the CO2 back to normal, looking at alpha stat blood gas management. This basically just reduces acidosis and reduces the embolic risk for when the cross clamp comes off. Now we'll look at modifying circulatory arrest to allow for cerebral perfusion. One of the ways of perfusing the brain is with antegrade cerebral perfusion. There's a few examples of how you can do it, but essentially the cerebral arterial vessels are selectively cannulated and perfused. Depending on how you cannulate, you might rely on this intact circle of Willis, but essentially the flow is around about 10 to 20 mils per kilo. The advantage is you can cool less because obviously you're perfusing the brain, which decreases some of the hypothermic complications like clotting and whatever. Reduces bypass time because obviously you're not spending all your time cooling and then rewarming. And then you have constant blood flow to the brain, and you can have selective temperature control as well. Another way to perfuse the brain during circulatory arrest is with retrograde cerebral perfusion. The brain is perfused via snared SVC and drains through arch vessels. The perfusion pressure is usually about 25 millimeters of mercury. You can extend the safe duration of circulatory arrest. You maintain a low intracranial temperature. You have less distal emboli than with antegrade cerebral perfusion, but the question is whether the perfusion is effective as you're perfusing retrogradely. Monitoring, obviously ECG, CVP, arterial blood pressure depends on what surgery the patient's having. NIRS, very important for ensuring cooling of the brain and then obviously rewarming of the brain, make sure that the nerves are still good. We measure temperature in the circuit and also of the patient, nasopharyngeal temperature, and maybe in the PA if you're using a cardiac output monitor. BIS and TOE. With thoracoabdominal aneurysms, we also have spinal drain monitoring as well. Any questions? Thank you.
Thank you, Jo. That was a fantastic overview and certainly explained a lot of the things that you just presume about the blood gas monitoring that I'd never really got my head around. I'm just going to see if there's any questions in the chat. Does anybody have any questions for Jo from the group? I don't think we've got a perfusionist audience, I'm afraid, so your fine details of how you actually do it are going to be lost on us. What, in terms of the difference between retrograde and antegrade, is there kind of a trend, or is it surgeon specific about what they do? Is there any reason why you wouldn't do antegrade if you kind of get the feeling it perfuses the brain better?
It mostly is surgical preference. I think there's more there's more surgeons doing antegrade than retrograde now, only because antegrade is physiological. But I mean, there's some surgeons that wouldn't even use cerebral perfusion. There is an argument for just getting on with the operation quick. I think with the NERS monitoring, you can see if there's any issues with the brain in terms of saturation. But I think, well, at St Thomas's, all of our surgeons use some sort of cerebral protection, mostly antegrade. I think there's only one that uses retrograde now.
Okay.
That answers the question.
Yeah, no, it does, absolutely. There's a question from the chat. Can you perfuse the body during circ arrest with a special pump setup? Could you perfuse the lower body using a...
You can. Sometimes if we're doing thoracoabdominal surgery that does need circ arrest, sometimes we perfuse the bottom half, for want of a better description, while the brain and the myocardium is ischemic. I mean, anything's possible. If you have blood pumps, you can perfuse what you like. It just depends on the nature of the surgery and the surgical preference. I mean, most of the time, if anything that involves the arch, we do circulatory arrest. As I say, if it was a thoracoabdominal setup, then we can perfuse the lower body as well, whilst the upper body's arrested.
Yeah, I was just thinking, I think we did a case which was a distal arch and descending thoracic aneurysm, when there was a time when you perfused the lower half as well as the brain, but there wasn't any. And then in thoracos, I presume you could do selective visceral cannulation of the celiac trunk and so on if you wanted to.
Yeah, we can do for thoracos. It depends. We did left heart bypass yesterday, as you know. Yeah. So with that, we can, because we're not cooling the patient very much, then we selectively perfuse the viscera.
But there's no reason why you couldn't do that if it's cold for the ones that need circ arrest as well.
Yeah, you can. Yeah, I mean, I think with dissections, hemi-arch surgery, we generally just do circulatory arrest, perfuse the head, and then go back on bypass. When it's thoracoabdominal surgery, it's slightly different.
Yeah.
Yeah.
One question on the chat is do you ask the surgeons to whether or not they've had a CT confirming intact kind of brain arterial anatomy? Do they have to have a confirmed intact circle of Willis for elective cases, or is that something you would just presume?
I think if there was any issues like that, the surgeon would selectively cannulate vessels to ensure both sides of the brain are perfused. and obviously the nurse would suggest if there was any problems with perfusion as well. So you can always adapt as the surgery progresses if there's a problem with the brain perfusion.
Okay.
But personally ask if they've had a CT of the circle of Willis. Maybe I should.
No, exactly. Especially if you're doing retrograde, perhaps. So another question is, can you give us an idea of the management of systemic potassium during circulatory arrest? At what phase, when do you tend to, if you're going to have to correct potassium, when would you do it? We wouldn't do it during circulatory arrest. I've never really had an issue with potassium specifically. Do you mean high potassium, I guess? It doesn't say in the question. That's okay. That we can ask. There's another question. At what site do you use for your temperature measurement? So I think you talked about at St Thomas's that they use nasopharyngeal and occasionally PA. Is that right?
Yeah, that's all we use at St Thomas's. We have temperature monitoring on the pump. We have arterial and venous temperatures, but the patient themselves, they just have nasopharyngeal plus or minus the PA.
I know that some sites do bladder as well, which is always frustrating because it seems to warm up much slower than the nasopharyngeal. But,
yeah.
Okay, I'm going to say thank you very much. We're encroaching into the tea break. Thanks for appreciate you you coming to speak to us.
Thank you.
And it's always good to have perfusion to explain, that kind of important thing in the corner that takes up half the room, and enables us to have a coffee break. So I'm going to pause the meeting there I think we're going to come back. I'm just looking at the revised programme. So the next talk will be Dr. Bozzetti from Glasgow, who's going to talk to us in 10 minutes at 20 to 4, sorry. So if everybody wants to kind of go and grab a quick drink and come back at 3:40, we're going to have our talks on TOE of the ascending aorta and arch.